We'll just give it a minute or so to let everyone enter. All right, we'll start. So hello everyone, and thank you for joining tonight. I'm Jackie Henwood and I'm the Research Project Manager at CERA, so Centre for Eye Research Australia. I'd like to thank you all for attending tonight's webinar. This is our 11th workshop, which is part of a series discussing artificial intelligence in healthcare, from data to algorithm to real world solutions. So these workshops are supported by the Medical Research Future Fund, and our goal is to connect the diverse skills of clinicians, researchers and healthcare workers with computer and artificial intelligence scientists. Therefore, we're trying to get everyone working together to develop and build AI solutions for real world healthcare challenges. So before I start, I'd like to acknowledge the traditional custodians of the various lands on which we connect tonight via our computers and pay our respect to their elders past and present. So tonight we're very lucky to have Dr. Kim with us, who will be discussing his experience with the application of artificial intelligence in eye care from his work at Aravind Eye Care system in India. So there will be a question and answer session at the end. So if you have any questions, please pop your questions in the chat box below and we'll go through them at the end of the talk. And now I would like to start by introducing you all to the very impressive Dr. Kim. So currently, working as a senior consultant of Vitreoretinal Services, Aravind Eye Hospital and Postgraduate Institute of Ophthalmology, Madurai. He has undergone fellowship training in the vitreoretinal specialty, both in India and later in USA. Now he's currently the Chief Medical Officer of Aravind Eye Hospital, Madurai. He has a keen interest in surgical retina and also has a special interest in telemedicine. He is one of the early pioneers to introduce tele-ophthalmology in India. Aravind Tele-Ophthalmology Network, through its vision centres, sees more than 2,500 patients every day. His current interest is in using AI, screening diabetic patients for the presence of diabetic retinopathy. Working with Google, he has deployed an AI-based screening tool for real-time use for diabetic retinopathy screening in India. Mr. Pichai of Google has honoured him by nominating his work as one of the best to happen in the next 25 years in the Wired magazine. He's currently Vice President of the Vitreoretinal Society of India and also of the Telemedicine Society of India. So without further ado, I'll welcome you all to Dr. Kim.
Thank you, Jacqueline, for that long introduction. And I want to thank Professor Ming He, Mr. Sanil, and team for inviting me to join on this and share our experience with all of you. It's a real honor and a pleasure to do that. Can I share my slides now? Can you see my slides? Great. So thank you again. And today, as you mentioned, thank you for allowing us to share our experience with AI and what we are doing with the AI at Aravind. You know, today we are in an age where what we call as the second machine age. There's a lot of electronic gadgets running around, and nobody seems to live without that. And we hear about these self-driving cars. Earlier it was a dream, but now it's almost a reality. We would see this. And more importantly, we keep seeing this. And we have taken it for granted. I'm sure 80% of the people don't even know that these are run using artificial intelligence. And they're almost like, it's an integral part of our life. So that's what AI has become. But AI isn't just transforming our products, but it's actually helping us to solve some real problems today. And in the future, this is going to play a major role. It's not only in, as I said, in the product, but even in healthcare. It's not only helping in diagnosing, but to improve healthcare. AI currently and in the future is going to play a major role. As far as India is concerned, India has been an early adopter for technology. And as you've been hearing in the news, the amount of usage of technology that is happening with the increased population in India, more than 700 million internet users. Almost 50 million people took digital health consultation in the last 3 months alone. It's been a tremendous increase, more so because of the technology adoption, the penetration of the internet into the rural areas to every corner of India today has been made it possible for technology to play or become very active. Just to give, for those who don't know what Aravind is about, Aravind is a group of eye hospitals, what we call as the Aravind Eye Care System, with a vision to eliminate needless blindness by providing compassionate, high quality, but more importantly, affordable eye care to all. So it's a group of many hospitals, like we have 7 tertiary hospitals, which has all these specialties, subspecialties of ophthalmology, and where the footfall is anywhere between 1,000 to 2,500 patients a day. And we have 7 secondary care hospitals, which does cataract surgery and basic surgeries, and with ability to do specialty diagnosis with a footfall of about 300 to 400 patients. And we have 6 outpatient clinics where we have only comprehensive ophthalmology. And more importantly, we have these 100 primary eye care centers, or what we call as vision centers. I will be giving you a brief about what these are. In the 1 year, Aravind had seen about 4.6 million outpatients, more than 500,000 surgeries and lasers and other procedures. Almost 50% of these are done free or steeply subsidized. That's why we meant it as affordable care to all. And telemedicine has come into, for the last 2 decades, Aravind has been using telemedicine in deploying eye care and creating access to the rural people. Today, almost more than 2,800 teleconsultations are done through our telemedicine network, connecting our rural vision centers with eye specialists, enabling access to eye care for the unreached. What are these vision centers? To address the issue of access for every 50,000 to 75,000 population, we have what we call as permanent low-cost eye care facilities, which are manned by a trained ophthalmic technician with linkage to the base hospital, so that it can provide primary eye care and referral services to that community which does not have access to eye care. So in a way, these are like remote rural facilities manned by 2 of the ophthalmic technicians who would examine these patients, just like what an ophthalmologist would do, a complete eye examination, including a slit lamp, fundus photo, appellation tonometry, retinoscopy and refraction. And all the data is entered into an electronic medical record. And once they've completed, they connect to the base hospital, where one of the ophthalmologists is able to access this electronic medical record, goes through it, and then through a video conferencing, low band web conferencing, they would connect to talk to the patient, so the patient can see the ophthalmologist and then advise him on further management, either to give prescribed glasses or medicines. And all these are given or deployed or dispensed in the vision centers itself, so the patient doesn't have to travel to the city or other place, so that everything is available locally. And only those who actually need any specialty care or refer to the base hospital. So this way, almost 85% of the patients are taken care of in the vision center itself, and only 15% need to be referred to the base hospital. So what is the role of AI? Before I go into that, I just want to give you a brief background as to where we developed this whole process. As you know, the recent publication from the International Diabetes Foundation has shown that the global prevalence of diabetics in the world is about 537 million, which is much higher than what was projected in the last year, about 465 million patients. So there's a huge increase happening everywhere. And India is one of the diabetic capitals with more than 77 million people living in India, which means the whole complications of diabetes, such as for the eye doctors, it's the diabetic retinopathy, which is very prevalent, and they need to take care of this. Unfortunately, as you all know, that diabetic retinopathy comes with no early warning signs. It's gradual in onset, and the decrease in vision happens mostly in the late stages, and patients are really not aware of it. So patients usually come to the doctor only when their vision is completely disturbed. It was seen in one of the studies that 45% of the patients with diabetic retinopathy attending the eye hospital had already lost the vision before this condition was diagnosed. This shows that we're not doing much about it. So it's very important that screening should be done, and it should not be limited to ophthalmologists. We have to find other alternative resources, and technology is one which can play a major role in helping the physicians screening diabetic patients. So this is what we did in the early 2001-2. We developed what we call as a software platform, what is called as Address. It's a semi-automated software which will assist the retina specialist to grade fundus images and then generate a report. We also created a mobile screening unit. So we put up what are these multiple screening units in diabetology clinics or the general physicians clinics, and then they've trained their technician to take fundus photos and send it through the internet to a reading center where our retina specialists would look at these images, generate a report, and this report is sent back to the clinic from where the patient originated from. And this whole process takes about 1 to 2 hours. And this we have been doing for almost these last 2 decades in this process of screening diabetic patients, what we call as opportunistic screening of diabetics when they come to the diabetologist or the general physician for their eye examination. This way, the patient need not go to the ophthalmologist. So we realized, we had developed our own software, which will help, as I said, the Address. Earlier it was called Dragon, which helps the graders to grade these images. In the process, as we all realized, retina specialists' time in sitting and grading is too precious. So we trained people to become graders in grading diabetic retinopathy. And this helped the graders to process more images in the day without wasting the retina specialists. But this process also has its own challenges. Even to get trained graders was becoming difficult. Retina specialist time, again, as I said, is very precious. And the time delay in grading and sending a report back was a problem when at the end of the day, the patients would not get their report, so they would get only the next day. So all these, and more importantly, one of the studies showed there's a lot of inconsistency among the ophthalmologists or among the graders, where they look at the same image and somebody may say mild and somebody may say severe and somebody may find a PDR. And so this kind of inconsistency was huge in one of the studies that was done by Google earlier. So we did work with Google in 2013. We started working with them to develop an algorithm or an artificial intelligence based algorithm for screening for diabetic retinopathy. We went through the entire process, though we were not doing the technical aspect, but we were there from not only by giving annotated images, but also through the process and also into multiple validation studies that we went through to develop this algorithm. But are these algorithms accurate enough or comparable to human grading? So it's been seen. This was one of the landmark papers which showed how well the learning algorithm and the diabetic retinopathy algorithm was working in detecting diabetic retinopathy. So the performance of AI was seen to be better than a trained grader or better than the general ophthalmologist, or it was even better or comparable to what a retina specialist was doing. So what it meant is that we could implement it in real time. So we went ahead and implemented it in 3 different scenarios. This was the diabetic retinopathy, diabetic clinics where we were continuing to do the screening. We not only did in diabetic clinics, but we also did in general physicians clinic. We had put fundus cameras. And so we replaced the retina specialist or the grader with the AI tool with a quick turnaround time. So almost instantaneously, the diabetic clinic or the general clinic was able to get the patient's AI report immediately. We also, in the primary care centers, in our own vision centers, we have a lot of vision centers which are now deployed with this AI tool. Earlier, conventionally, the images taken are seen by the ophthalmologist in the base hospital. Today, it's an assisted read. The AI does the grading before it even reaches the ophthalmologist, and the ophthalmologist is able to compare with his own findings. Again, even in our general clinic, where we are seeing patients in the tertiary hospital for assisted read, when the patient gets registered and he's a known diabetic or says that his random blood sugar is very high, we would take his fundus photos, undilated fundus photos before itself, or in certain situations we would do it after, but most often it is done undilated, and then the patient is sent after dilatation to the ophthalmologist, who would have this as an assisted tool to assist or assess the fundus image of the patient that is sitting in front of him. So the criteria for DR screening was the age of the patient above 40 years and above, with or without diabetic status. All known diabetics in the age above 18 years, if the random blood sugar value is more than 200 milligrams per cent for any patient when we did in these vision centers, or even if any patient had any retinal pathology seen by the vision center technician, they would take a fundus photo for these patients. We had a strong monitoring system that is in place where we actually assess every single image that is sent up to ORDA. On a weekly basis, this is seen. As you can see, the gap where no cases were seen was because of the COVID impact in the first wave. In the second wave, we did not do it in the vision centers, but the diabetic clinics continued to screen patients for diabetic retinopathy, and that's the one in the green that you see. This is another thing that we would see looking at it, the severity, diabetic retinopathy severity, diabetic retinopathy gradability, and stuff like that, so that we will be monitoring. We have a tool to monitoring on a periodical basis how things were happening. So this is just to give you an idea on the performance of how we have been doing after implementing in real time since July 2019. Whatever was done earlier before this was all in multiple validation phases that we had done. So this is to show that the general hospital, the diabetic retinopathy percentage was about 17%, whereas in the diabetic center, it was 32%. This is because we are screening all this diabetic center particularly was looking at all advanced diabetics. And so obviously these numbers were very high. Whereas in the general hospital, there were not only patients with diabetes, but the other patients who walked in were getting screened. And then that number was, so the prevalence was lower in these patients. In the vision centers, it was only 8.5% because we were seeing across all strata of patients. Whereas in the eye unit, which means the general units that when the patient is coming into the hospital, the numbers were quite high because these are patients who are only diabetic with eye problems were being screened, and that's the number that we see as high. Looking at the ungradability of these images, again in the diabetic center, all the patients, this particular diabetic center was dilating all the patients, so the ungradability was high, whereas in the general clinic, it was not dilated. And so our ungradability was higher in these places. In the vision centers, it was around 15%, again, possibly because these are the patients who have like cataract associated problems. We have not looked into that data yet. In the general units where the patients are coming, again, as I said, these are patients with eye problems, many of them with cataract as a problem that they come in the general units. And that's why another reason we have a very high ungradability in these patients. We also looked at after this validation period, once we have gone in real time, we've been doing a random validation of these images. Our retina specialists would pull out certain images and look at whether ADA or the algorithm is missing a referable DR, and we found it was as high as 3.5%. When we were doing before these real-time validation studies, it was around 1 to 1.2%, but now we realize it's a little higher, and we need to look at how we train these patients, or train the technicians in all these locations, all the different locations, on improving the quality of the images, improving the gradability, and the quality of the images is what we feel is responsible for this missed referrals. So there are very many challenges that are happening in this, in deploying and using AI. One is the environmental challenges, the different scenarios in the different light conditions that we need to take fundus photos. The very important thing is the human challenges, the operator's skill to take fundus photos. Trained technicians keep changing in many places, especially in the diabetic clinics. And the changing priorities is another problem, where they don't tend to take pictures, or pictures are taken in a not so careful manner. The other one that I've not added here is the use of different cameras also play a role, where high-end cameras have a much better gradability, and outcomes are much better compared to low resolution cameras that are being used. So we have been trying to use multiple different range of cameras in various scenarios. Patient factors, again, it's very difficult to convince all the patients to get the fundus photo taken. And again, patients' compliance to follow up is also very, very difficult in spite of extensive counseling done for these patients. The other factors, as I said, are the ungradable images, presence of cataract or undilated pupil. Indians tend to have a very small pupil compared to the Caucasians. And now, as you know, that single 45-degree field is what is taken in these patients. Today, we have any number of algorithms that are available in the market for people to use. So it's there in real time for anybody to use these algorithms for DR screening. So as you could see, the numbers have really gone up for us for screening diabetic retinopathy compared to pre-AI era, where we were doing only 1/10 of what we are screening today. So in future, how will AI help us manage eye care better? It is not just screening as in diabetic retinopathy or soon in glaucoma and other conditions. Even in diagnosis, like now we can, looking at the fundus photo, we'll be able to say whether there's a center involving diabetic macular edema without even doing an OCT. And so those algorithms are coming up, and we would soon have just to take the fundus photo, and that will be telling us whether we do or seeing. Like in these two pictures, you can see, though the fundus shows hard exudates and the presence of the, like you would suspect macular edema, in this, there is no center involving macular edema, while the second one doesn't seem to have much changes, whereas on OCT, there's a clinical center involving diabetic macular edema. So how would will OCT help us to, will AI help us to identify diabetic macular edema just looking at fundus photos? So there are deep learning algorithms to detect OCT-derived diabetic macular edema from just color retinal photographs. And again, there are many attempts in many places to show this is possible. Another important using prediction is there by looking at the fundus photo or the OCT, will the system tell us, or will the algorithm say that this patient would respond to a particular anti-VEGF or not? That will be the day. And then we can decide on giving the treatment based on these predictions. And this is coming in real time. There's a lot of experiments happening at this point of time, but it'll be the future. Recently, we have joined hands with, of course, the Center for Eye Research, Dr. Ming, Professor Ming, his team, to do a pilot study to optimize an artificial intelligence algorithm for detecting diabetic retinopathy and glaucoma using a specialized fundus camera, which has been worked in Caucasian populations, but to see how it works in an Indian population. Sorry about that. So this we are working. This is yet to start, but we'll be starting in the coming next few weeks. We're looking at how AI can work, artificial intelligence, and can help in primary care settings. One of the major constraints in these vision centers that we are doing is the human resources, having trained the graders, especially to live in the rural areas. This is not a problem of us alone, but it's a global problem to have people or specialized trainees living in these remote areas. So if AI tools can be identified to triage the patients, so only those who have a problem will be referred to the ophthalmologist, saving the ophthalmologist's time from screening these patients. And we hope that any untrained person will be able to operate these AI-based tools in the primary care settings. In this effort, we have again joined hands with another group in Australia. This is the Australia-India Strategic Research Fund, where we are doing a collaborative project with the Notre Dame University and the other team to validate a set of digital eye disease diagnostic devices which will be suitable for AI integration, and will integrate it with AI-based clinical decision support systems for diabetic retinopathy and various other conditions. So if this could work in our vision centers, we feel that this learnings will benefit the Australian indigenous communities and those living in many rural and remote locations in Australia. This will play a major role in different of those aborigines and many other communities living in remote areas. But like all technology, the impact of artificial intelligence will be very profound only when it can be accessed to a lot of people. And as they say, still there are many more ideas that and there is no end or no limit to this ideas that will come up in future in using artificial intelligence in our day-to-day activity to improve the quality of life of many people. So as our founder used to say, intelligence and capabilities are not enough. There must be a joy of doing something beautiful. And I once again thank Dr. Professor Ming He and his team for giving me this opportunity to share our experience on using AI. Thank you.
Thank you. That was a really great talk. You've already got some questions in the question box. Are you happy to for us to go through some of them?
Sure. But I'm not seeing any questions here. Oh, here in the question box.
Q&A.
Right. Okay.
So one of the questions was, or the first question was, what are the fundus cameras that are mostly used with the algorithms, and what's your experience in running them?
Yeah, so we have used all the Topcon NW400. We have also used this Crystal View cameras, but majority of them we had used is the local Indian-made fundus cameras like the Forus which is now available globally, and also in some situations, the Remedio camera, both are Indian-made cameras. So these are the cameras that we have used in our various different locations. And what are my recommendations for the ungradable fundus images? By default, our system says that those ungradable images are considered as referable DR, because these patients, usually we are training, when we do the training for the fundus photographers, we tell them how to take good photographs, and these ungradable photographs, we ask them to retry in these patients. But again, we cannot do anything about those patients, especially in the units and in the eye units, patients coming with cataract. In India, patients develop severe nuclear sclerosis even above the age of 40, as early as 40. And our pupils are also very small compared to the Caucasian population for whatever reason. So that's another reason why we have ungradability very high.
Well, if anyone else has any questions, I'll let them add them to the chat box. I do have a question. How do you find the patients? Do you tell them that you're assessing their images with artificial intelligence, and do they have positive experiences with it?
Yes, that's a mandatory thing that we have to do. We have to get the permissions, all our validation throughout the process. We are taking an informed consent with the patient. But we are doing that in the diabetic clinics, but not right now. We are not doing that in our vision centers, where we are continuously doing the screening, because here it's not just the artificial intelligence alone, but it is also being seen by the ophthalmologist. So that's the reason we don't take a special concern for using an artificial intelligence. And the volume is also very, very high, as you can see in the numbers. Whereas the diabetic clinics, we still continue to take an informed consent for using artificial intelligence in these patients.
And do people in those clinics, do they happily, do they trust the results, and do they seem happy after they consent?
They seem to be, I mean, in the sense for them, I don't know, the educated people do ask questions, but there are very few who ask questions about, because they take whatever the doctor advises them, the diabetologist or the general physician advises them, they take it as the golden word. And but they know that this is being done, this is being screened and validated with the information coming from Aravind Eye Hospital as a mark. So
yeah.
I mean, that's a good question, because we have been trying to interview the satisfaction level of, I guess I would ask Sanil to come back and do more work on that. But we need to do that. We haven't really gone into the satisfaction quotient of our patients screened for diabetic retinopathy using artificial intelligence.
And I suppose to lead on from that, you haven't, maybe not the patients as much. Do the ophthalmologists or the healthcare workers, do they enjoy working with the artificial intelligence as well? Do they comment on that?
Definitely, because they are very happy to see that, that they have a data that is coming in. They don't have to go through the grading of images. And especially in the early cases, many times I've seen people who have been surprised and they say, I can't see anything. But then the artificial intelligence says this patient has mild NPDR. So then I've taken those pictures, taken it to a bigger computer and zoomed it and showed them how the eye can miss those small microaneurysms, which the human eyes can miss. So it's really interesting, and of course for the people who are working on it, find it very, very interesting.
Definitely. We've got a few in the chat now, so I might ask a couple from here. We've got a question here. What is the potential of OCT detection of diabetic macular edema in the real world?
Pardon, what is that? I don't see that question here.
It's in the chat box, sorry.
Oh, okay.
It was from Wenyi.
Okay, I'm moving that, yeah. In terms of oh, there are a lot of questions here.
There are a few now, yeah. It was at 5:39.
I have it as 1 o'clock, so sorry.
Oh, sorry, yeah. Sorry.
What is the potential of OCT detection of diabetic macular edema in real world? Yeah, so this is actually, I mean, today this is still in the experimental phase, but I see that it is not just every machine. One, the OCT machines may come with, automatically giving the reading, after reading the OCT, the entire data may be there, and it may not be needed for the ophthalmologist to interpret the OCTs. That's one thing that may happen. And looking at the fundus photos to look for diabetic macular edema, I think that I feel that there's a huge potential for that. I mean, think about that. You don't need to do a OCT for every patient every time he comes. Just a simple fundus photo can be enough to guide you on managing these patients. So I feel that there is, especially as a screening tool, this will be remarkable when you have OCT to detect, I mean, a fundus photo with the AI to detect diabetic macular edema. So the next question is, how can you manage the predictability of grading diabetic retinopathy based on a single fundus photo, mostly imaging the central retina? Good question. Even I have this, we need to ask, because there's a lot of longitudinal data that is going through this to look at how the images are looking at the different fundus photos and they're also comparing it with the OCTs and working on to develop this algorithm. So this is currently being done by my friend in Shankar Netralaya, and with the Zeiss team. They're working on to see how this is a work in progress, but what it shows is it is possible as long as you have enough data to do this prediction, because prediction, it is, I know for sure there's a paper that has come out of Google. In fact, we will be part of the process is to see whether a patient who is a diabetic patient who doesn't have any diabetic retinopathy today, by just taking his fundus photos, what are the chances he'll develop diabetic retinopathy in the future? This is something that is possible, and the algorithm has been developed but needs to go through a lot of validation. Again, as I said, it needs a longitudinal experiment to prove how these things work. So what it says is there is a possibility to do that.
I think what she tried to ask is also about grade. How accurate is the grade DR grading when this photography is really based on one single central retina photo, one single photo?
Good question. I don't have an answer for that, because I don't know how it technically does, but there seems to be, because in any diabetic retinopathy, we see that the changes are happening at the posterior pole more so to start with. So there is something that's happening in the retinal layers or the blood vessels, the caliber which the human eyes is unable to see, which the algorithm is able to detect over based on what it has been taught over a period of time, with different images of the same patient in different periods of time, whatever learnings that comes out of it, I guess that is what it is using to detect. How accurate will be, only time will tell.
Yeah, great. again, Dr. Kim, I think thank you very much for your time, and because this is a fantastic talk. But then I just got a few like questions that the first question I really want to understand is, are we able to run a study? Because at the moment, I understand your the AI algorithm deployment is more like a proof of concept, like a research or experiment. It's not a real service provision process. So, but then are we able to run a simulation study? We just simulate there's a reading center, and then there's a DR, I mean endocrinology or this diabetic clinics, and running sending in image comes because actually you're already running this real DR screening program as an opportunity screening model in the diabetic clinic already. So we can actually simulate the accuracy. We can compare the grader, how accurate is the grader, when they deal with the real world image, and how accurate is the AI algorithm. Because you see what I mean? We can run a simulation study to simulate in a 1 week, like we just use the retrospective data, the data that we are collecting, for example, in a specific 1 week time, and then we can see how, and then we run the AI through every single images in this 1 week, and then we can compare the accuracy of the AI in this real world image and with our reading center. So would this something that you're interested in running, or?
You're saying about just detecting detecting diabetic retinopathy, right?
Only DR, yeah.
Only DR. Yeah, but that's the validation studies. We did multiple validation studies to see how the algorithm performed. Earlier, even before we went for real time, we did at least 4 large validation studies. We also did validation studies using different cameras, where the fundus photos are taken from the diabetic clinics. And these fundus photos are independently read by the retina specialists, read by the graders who are trained graders, and then the AI algorithm was doing its own grading. So then we compared all the 3 to see how they perform.
Yeah.
So is that what you want to repeat?
Yeah, but then in the real world, I assume this challenge in terms of small pupil or nuclear sclerosis, poor image quality, they can equally affect the accuracy of the image grader as well.
Yes, true, very true.
Yeah. So then they unless you are like sometimes just because in the real world, I mean, the technician may not just, they may just don't bother to dilate the pupil, and then the image is not in a good quality. But then when this poor image quality, poor quality image being graded by an image grader, they will also come up with some problem. I mean, they will compromise the accuracy, but then it will also compromise the accuracy of the AI. So in my understanding, a good AI should be able to handle all these challenging images.
Exactly, that is true.
As good as the image grader.
Yes, as good as the image grader or better.
Or better, yes.
Yeah. So that's the thing, like, many of the algorithms are claiming to, like I was showing you the different algorithms that are out there, which says, they are very good even with the low-end fundus cameras, any fundus cameras, even images taken with a mobile phone attached to a device taking fundus photos. So I really don't know what that claim is based on, but you are absolutely right. We need to have the algorithm to be as good as the grader, or in fact better.
Yes, absolutely.
So yeah. Are you suggesting that we should do a study, Dr. Professor?
I think so. We can run a study using the image already be collected, and then retrospectively, like it's in a specific, like for example, a specific 1 week time, and then we run through all these images with the AI, and then we compare how this gradability and also what's the outcome at the accuracy with the image grader. And then we can also ask retina specialists. To be honest, I don't think a retina specialist is helpful because for real world images, because they may not even know how I should grade DR. I mean, they don't really understand what's the grading scheme at all. I mean,
they don't have the time also. That's
yeah, right.
all the time.
Yeah. So on a study like this, and then because the problem for any reviewer or editor-in-chief keep receiving a lot of publication with like a 99% accuracy, 95% sensitivity, 91% specificity, but then you're not sure how well this AI really, I mean, how good it is. Yeah.
See, the other day, one of the guys came and told me, we have this AI algorithm. I said, we are already using something. He said, I can bet with you there's no algorithm in the whole world that can be better than what we have. I said, how do you compare? It's not apple to apple to compare it. So,
Correct.
yeah.
Good.
So,
and then
we can discuss that to do that.
Yeah, and then we can think about like maybe use the APTOS to set up like a standard data set, including the poor quality image, good quality, whatever, and then we can block it as a way to test the AI algorithm accuracy on both like good quality image and also poor quality image in the real world, that collected in the real world. That would be quite a meaningful work.
Exactly. Yeah. We could do that in the images that have been collected in the real world, as you said, in the retrospective data, and then run through this like what we did for the Aptos, the competition that we held.
Yeah.
For the different algorithms. We could do that and see how they perform.
Fantastic. Thank you so much. That's all my question.
Thank you.
We probably have time for a couple more. Do you have time for a couple more?
Sure. Yeah, we have another 8-9 minutes.
Yeah. So I might go back more to the top of the list. Someone did ask, what are the main challenges to apply AI developed in the lab to the real life scenario or real world clinic?
What are the challenges in moving from?
Sorry, I've gone back. Sorry. I need a minute. You can talk.
Yeah, so it's basically translating research findings to real world practice. What are the challenges you face?
As I said, even in our own scenario, when we were doing it as an experiment, we had very little missed referrals. But when we went into real time, we take probably the way we do things is taken for granted, and then we did see there's an increase in the number of missed referrals. When I say missed referrals, when the same image is graded by a retina specialist or a trained grader, he thinks it is more than moderate or more than moderate or more than that, which means any of that should be a referral criteria. Whereas the algorithm has graded it as mild or no DR, which means we have missed an opportunity to refer that patient. So that is what I meant by missed referral. So we see that happening. And as you said, the quality of the images are also tend to lose with time. When I say tend to lose, because the actual macula-centered images and is not taken. People tend to take in different fields. All that also adds to the errors that can happen in these patients. So that's a challenge that we have. And again, a repeated training of the specialists the photographers is very important. Unless you have those, today there are many cameras which have come automated cameras. So they actually help in the focus. Whereas when you have these low end or manual cameras, there's a lot of retraining that is needed in many situations. So you need to monitor the quality, which we are doing, as you saw in this thing, how well this whole AI is performing in comparison to if a human grader did it. So we do these periodical audits. So those are some of the challenges that we will have. But we need to, because until we just moved from humans to a machine. When the humans made any error, it was not noticeable. Whereas today, when machines make an error, though they are very consistent, though they are unlikely to make mistakes, unlike the humans, we still, will prefer to have human graders than the machines. That's a tendency, but those are the challenges. But people acceptance, from the patient point of view, I don't see that as a major challenge. It's only for the providers that whole, you have that hesitancy. Yeah.
So another question that has come up is, so we have been explaining more about the DR, where AI is being used for DR screening. So do Aravind has any plans to use it in other specialties for other eye ocular conditions?
Professor Minghi is giving us an algorithm to work on glaucoma. So we're going to try it out. We have not done that yet. So though there are many algorithms that are out there, we have worked with few companies, not companies to engineering institutions to develop for glaucoma, but that none of them have been successful yet. So we are looking forward to it. Google has been working, but they also have not translated it into a product yet. It's still not being validated so much as they have done it for diabetic retinopathy. But again, there are so many other AI companies which claim that they can do vein occlusions, that they can do glaucoma, they can do age-related macular degeneration. We also experiment with a local company to detect cataract using mobile phones on a door-to-door survey. This is for the government of Tamil Nadu that was done, and they have developed a device or an algorithm to detect as a screening tool to diagnose cataract using AI. So this is our experience with other conditions. Yeah. Sanil, any other questions on this?
Yeah. There are a couple more. So this someone is asking how much is the Dr. Ganesh Babu is asking how much is the market potential value of these, and what's the expectations for people to adopt or buy the service?
Today, I don't see that as people will not move. Like in India, we are trying to bring in a huge change, not among the ophthalmologists, but among the physicians and the diabetologists who are providing diabetic care to use these algorithms in their regular screening of their diabetic patients. There, the potential is huge, as you know. It's globally that is the area where the patients should be screened for diabetic retinopathy, not in the ophthalmologist's office. So I keep promoting this idea that the onus of diagnosing diabetic retinopathy is not with the ophthalmologist, but it is with the general physicians and the endocrinologists and diabetologists, because they are the patients who are handling these diabetic patients. So looking at that, the potential for using these AI algorithms in future is quite high. With the devices like the fundus cameras, the cost of it is coming down dramatically. I think with the AI integrated fundus cameras will go a long way in identifying not just diabetic retinopathy, but various other conditions too. Yeah.
There was a question here as well about the address or the ADRES software, and what classification of diabetic retinopathy has it used in that software?
When we developed it, we used it using ETDRS classification. So we actually ask what happens is that a fundus photo is taken. In the beginning, we used to take 5 field fundus photos. So for every image, a set of questions will pop up based on the ETDRS criteria, and whether our hard exudates present or hemorrhages more than the standard 2A picture or things like that. So the grader has to look at the image. They will have a comparative standard 2A picture to compare, and then they will say yes, no, or not gradable, things like that. So based on that input that the grader is giving, the algorithm will say patient has got a mild, moderate, or severe diabetic retinopathy. So it was based on the ETDRS criteria at that time. I can't hear you. Your audio's.
Hear me now?
Yeah.
We have a couple left, so did you have time for any more, or
It's
time now?
Yeah.
We can yeah, that's okay. Thank you so much. We can wrap it up there, but there was your talk was too good. You had too many questions. So thank you so much for the night. The talk was really good, and obviously with all the questions, everyone was really interested. So thank you so much for your time, and maybe we'll be able to have you back sometime.
Wonderful. Thank you. Thank you all again for the opportunity. It was nice meeting with all of you. And thank you, Professor Minghe.
Thank you so much, Dr. Kim. We have a lot to do now after the meeting. Thank you.
Yep.
So much.
Sanil, you're really enjoying. Looks like you're really enjoying the Australian.
We have a great team here.
Yeah, you're also enjoying the winter. I think now we have the summer.
Yeah.
So.
All good.
Okay. Bye bye.
Thank you everyone for tuning in, and I'm going to end it now. Thank you. Bye.